Welcome. Thanks for joining us on our Cochrane seminar, an overview of surfactant treatment, the evidence from systematic reviews. I'd like to extend my welcome from our core editorial team, Bill McGuire, Colleen Ovalman, Claire LaFrance, and myself, as well as our senior editors, Jeff Horbar, Prakash Shah, Suresh Gotham, Jackie Ho, David Osborne, and our ever-growing group of associate editors, including 3 new additions who I'd like to personally welcome: Dr. Suvik Mitra, Dr. Matteo Brusciatini, and Dr. Nai Ming. Of course, I'd like to thank our sponsor, Vermont Oxford Network, who are the host organization for Cochrane Neonatal and provide financial support and resources for the creation and dissemination of systematic reviews on the evidence for newborn care. Our reviews are posted free of charge on the Cochrane Advan website with the address below, and I encourage you all to visit the site to look at some of the reviews that we'll be discussing today. From a point of view of disclosure, I am the Vice President of Vermont Oxford Network and the coordinating editor of Cochrane Neonatal. I've previously been a principal investigator on some of the trials that we'll be discussing today and have been a paid consultant for several of the major pharmaceutical companies that produce surfactant, but I have not done such work in over 10 years. And I have no other relevant financial issues to disclose. Our hopes for this series of seminars is that it will help to develop an understanding of the strengths and weaknesses of evidence provided by systematic reviews and meta-analyses to inform our practice of neonatal perinatal medicine. Today's focus will be on optimizing surfactant administration in preterm infants. Specifically, our learning objectives will be to be able to describe the clinical impact of surfactant therapy and to discuss the changes and indications for surfactant therapy in the context of current practice, particularly our use of less invasive respiratory support, and to appraise and gain insight into the new potential delivery methods for surfactant formulations and how these might improve infant outcomes. In our flipped classroom, we'll invite our 2 guests, Dr. Daniel Ehert and Dr. Deirdre O'Reilly, my colleagues here at the University of Vermont and experts in evidence-based medicine, to help host a session where we'll look at your local guidelines as well as your personal practice choices and discuss the evidence that supports or refutes those choices. Let's start with just a little bit of basic science. The importance of pulmonary surfactant was first reported in the 1950s as being critical to the problems of respiratory distress syndrome. Originally thought to be dipalmitoyl phosphatidylcholine, it is now recognized that pulmonary surfactant contains many other phospholipids and has a critical protein component, making up 8 to 10% of pulmonary surfactant, including proteins A, B, C, and D, which have functions beyond just surface lowering capacity and are very important to adequate surfactant functioning. We also know that surfactant has a very complex metabolic life in the lung. It's created in the type 2 cell and extruded into the airspace, where it forms a monolayer that has to form and reform in the dynamic conditions of the lung. Surfactant coats the alveolus and lowers surface tension, which will improve lung compliance, seen here in the lowest figure. In a poorly compliant lung, it takes a great deal of pressure to generate small volumes, and on deflation, there is collapse of the lung. In a normal surfactant sufficient lung, we see a much improved pressure-volume relationship, where small changes in pressure lead to large changes in volume, and we see much better deflation stability, the so-called phenomenon of hysteresis, in the surfactant sufficient lung. There have been many investigators worldwide who have moved this field of research forward, from the bench and our basic science understanding of surfactant to the animal work to understand how it might work in the newborn to running the clinical trials in sick preterm infants. And we are all indebted to all of these people, myself quite personally. I think it's always fun when we take a look at the evidence to try to match it up with a current set of guidelines. And here we have from the Canadian Pediatric Society some very recently published guidelines regarding the use of surfactant replacement in neonates. This was published in 2021, so quite recent, and is easily available at the web address noted below. Let's discuss some of their guidelines. First, there have been decades of clinical trials and systematic reviews that have established the unequivocal benefits of surfactant replacement therapy for neonates with respiratory distress syndrome. These studies used two so-called treatment strategies. The prophylactic strategy refers to the use of surfactant when infants are at risk of RDS, not being necessarily symptomatic with RDS, with an aim of preventing severe RDS from developing. A selective strategy uses surfactant in infants who have established signs and symptoms of respiratory distress syndrome. So prophylaxis is given to at-risk infants, and selective is given to infants with established disease. We've published multiple reviews in the Cochrane Library that have delineated these early trials. There are over 32 trials involving 6,773 infants. And I'd like to review them for a moment here, just so that we remember what we expect of when we give surfactant therapy. Well, first, we expect to see a profound decrease in the risk of pneumothorax. Whether or not trials were done with a prophylactic approach in high-risk infants, or whether they were done in treating established respiratory distress syndrome, whether they were done with what at the time were non-protein containing synthetic surfactants, mostly Exosurf neonatal, or a variety of animal-derived surfactants from mammalian sources, we see a large decrease in the risk of pneumothorax. The risk of pneumothorax could be reduced from as little as 5% to as much as 17%. This risk was reduced no matter which preparations we used and no matter which approach we used. But I don't think we'd all be quite so thrilled about surfactant replacement therapy if all it did was improve blood gases and decrease this acute lung injury. What is important is that surfactant replacement therapy has had a clear impact on neonatal mortality. Whether used prophylactically or as rescue treatment, whether this non-protein containing synthetics were used or the animal-derived surfactants were used, we see a large decrease in the risk of neonatal mortality. This risk could be as little as 5% absolute risk difference, as much as a 9% risk difference. Even the smallest risk difference, a 5% risk difference in mortality, suggests that for every 20 babies we treat, one less baby will die from complications of respiratory distress syndrome. Although we don't see an effect on BPD looked at alone, we do see a decrease in the risk of BPD or death, which can be thought of as the converse, namely more survival without BPD. We certainly see this in the rescue trials of the infants who have established disease, and a suggestion of improvement of BPD and death in the trials that involve prophylaxis. There are many surfactant products which have now been developed, including animal-derived products that have bovine or porcine origins, the pure synthetic products that were originally tested, like Exosurf neonatal, and now more complex synthetics that are peptide containing. These peptides mimic portions and domains of the surfactant proteins and vastly improve the surface activity of these preparations. These have all been tested, but they won't be the focus of our talk today. What we will focus on is the various approaches and strategies to treatment. And first, let's talk about this very fundamental issue. The original trials looked separately at prophylactic treatment versus selective treatment, but it begs the question, which is the best approach? Both have been shown to be effective, but in our current day and age, where we are focusing much more on avoiding intubation, what's the right way to pursue this? Well, when we look at the basic science, there appears to be a strong rationale for considering early prophylactic therapy. In this animal work by Dr. Jobe and his colleagues, it shows that surfactant, shown here on the left, when delivered into a fluid-filled lung, has a very homogeneous distribution. But when delivered into an air-breathing lung, we see a very helter-skelter, heterogeneous distribution, suggesting that surfactant will be much more effective if given earlier in a fluid-filled lung or one in which there hasn't been long established air ventilation. Here's an even more striking example of why aggressive therapy might be better. Here's an animal model that was either treated with surfactant at birth or ventilated for relatively short periods of time, as little as 12 or 15 minutes prior to sacrifice. On your left, you see the surfactant treated lung, and what you see is widespread and homogeneous aeration. On the right, you see an animal that was sacrificed after only, like I said, 12 or 15 minutes of air breathing. And what we see is widespread atelectasis, but also following the black arrows, we see areas of bronchiolar necrosis, suggesting that even just minutes of positive pressure ventilation and oxygen can begin to cause serious lung injury. So that argues for the fact that aggressive early therapy may well have some benefits. There are now multiple trials that have been done to address this issue, and in this review from Rojas Rejas and others, we compare prophylactic and selective therapy. There are 11 trials involving 4,507 infants. What's interesting about these trials is that they have literally spanned decades, entirely different periods of time in terms of neonatal intensive care. The first trials were done shortly after surfactant was approved in the 1990s. And you can see here that these trials were done without the routine application of nasal CPAP. In the trials here, there's the occasional trial that showed a decrease in mortality associated with prophylactic surfactant, namely the Bevilacqua trial here, the Catwinkle trial, the Kendig trial, and the Walthy trial. But more importantly, when we look at the typical estimate, we see a very significant reduction in neonatal mortality associated with prophylactic surfactant treatment. The point estimate suggests a 31% decrease in the risk of dying, and the confidence interval, as you can see, is quite precise and quite narrow. Apparently, a very positive result in support of prophylactic surfactant. But this is what's interesting. Things change, the context of care changes, and the various risks of the newborns we care for change. During a similar time period throughout the 1990s, we began to embrace the use of antenatal corticosteroids to help improve lung maturation and newborn survival. In fact, all during this period of time that these studies were done in the 1990s, we had suboptimal use of antenatal corticosteroids. It isn't until the present day that we've reached levels of 85 to 90% of all very low birth weight infants receiving at least some antenatal corticosteroids. Interestingly, what we know is that there may be a synergistic effect of getting surfactant and antenatal steroids. Let's read this figure in reverse. If you don't get either surfactant or steroids, you have a very high risk of dying from RDS. If you receive surfactant, no surfactant, and get antenatal steroids, or if you receive surfactant and get no steroids, you actually have very similar risks of dying. But if you receive both, you have a very significant improvement in your risks of potentially dying, suggesting a synergistic effect between these two treatments. In addition, we've changed our entire approach about how we stabilize and treat babies regarding less invasive respiratory support. Here is the figure from Avery and colleagues' work where they compared the 8 score centers regarding their rates of what was then determined as BPD, namely oxygen at 28 days, and noted that Columbia University in New York had a strikingly lower rate of BPD and had a strikingly different approach to treatment, including the aggressive use of nasal CPAP. CPAP has now become a mainstay of our therapy, and so it's interesting to ask, what do the more recent trials of delivery room management tell us about this question of prophylaxis versus selective treatment? There are 2 studies which specifically address the use of prophylactic surfactant in an at-risk population. There are others, such as Coyne and Sandre's study, which treat a slightly different population who have had very early signs of RDS. But let's focus on the 2 studies that are directly similar to the studies from the 1990. Interestingly, both the support trial and the trial of Dunn and colleagues through the Vermont-Oxford network both showed quite the opposite effects that were shown from the studies of the 90s. There is, in fact, an increased risk of mortality in the group that got the prophylactic surfactant, as opposed to the group that received nasal CPAP and selective treatment. When we look at the typical estimate, there is a strong trend that suggests the opposite from what we saw earlier, namely mortality in this case is improved with the less aggressive approach of stabilization on CPAP and selective treatment. When we look at the combined outcome of death or BPD, we see in these 2 studies a small but meaningful improvement in the outcome of death or BPD associated with the less aggressive approach, namely stabilizing on CPAP and selective treatment with surfactant. When we look at this and compare it to the studies in the 90s, so the earlier studies without routine application of CPAP, which showed a very important decrease in mortality, is not supported by the earlier studies. And when we combine these studies in a meta-analysis, we see we no longer see the positive effects that were reported from the 90s. And in fact, as we think about our practice, it really conforms much more to these recent studies. Our practice has changed accordingly. We are intubating fewer infants in the delivery room for the purpose of giving surfactant, but if intubated, actually, more of those infants are receiving surfactant, which probably represents a very good merger of the 2 approaches to care. Let's discuss a little bit about early versus delayed surfactant in the context of the baby who is already intubated. There is a review comparing trials in intubated babies with RDS about whether treating earlier in the course or waiting until there is worsening of disease and a higher oxygen requirement will lead to the best results. There are 6 trials involving 3,577 infants. These trials included both some large trials of synthetic surfactants and the trials that are probably of more interest to us regarding animal-derived surfactants. But in either case, what we see is that there is a trend, if not a significant effect, towards decreasing mortality if we treat these intubated infants earlier with surfactant therapy. The punchline here is that you may not have to intubate, as we learned from the last set of studies, and you should try to support on CPAP, but if you intubate for respiratory insufficiency, you should give surfactant very shortly thereafter. So that is the big question. How then do we decide we should use surfactant in the preterm infant who is on non-invasive respiratory support? We don't have a recently updated Cochrane review on this subject, and so I've chosen Ishiyama's recent review on non-invasive ventilation with or without early surfactant as an example of whether or not this process of intubation for the purpose of giving surfactant with rapid extubation is a valid approach. In this meta-analysis, they find 9 trials involving 1,551 infants. And here What they show is that there is a trend, but no significant effect on decreasing death or BPD when comparing INSURE, intubation, surfactant treatment, and rapid extubation, to nasal CPAP and selective treatment. The relative risk is 0.88, but the confidence interval spans from 0.76 to 1.02. The Canadian Pediatric Society writes quite perceptively that these studies suggest that the use of nasal CPAP shortly after birth as a primary mode of respiratory support is an acceptable alternative to elective intubation and administration of prophylactic surfactant. However, the criteria for surfactant administration on infants who are on CPAP is less clear. We don't know when we should pull the plug, intubate, and treat these infants. They also note that one of the potential issues with INSURE is the perceived difficulty of extubating babies who we intend to rapidly extubate after treatment. In a 2015 review, it showed that over 90% of infants were successfully extubated within 1 hour of INSURE treatment. But that again brings into question, 1 hour of positive pressure ventilation is really quite an exposure. And that is why, as we'll discuss later in this talk, we're thinking of even less invasive ways of delivering surfactant to these babies who are stabilized on CPAP. And that brings us to this whole idea of, are there some newer techniques of surfactant administration that we should be considering? Well, there are several being tested. There's thin catheter administration, using a thin catheter defined as something much less in caliber than an ET tube, a catheter that you could not administer positive pressure ventilation through. You've heard this by the name of LISA, less invasive surfactant administration, by the name of MIST, minimally invasive surfactant administration. But what they share is the fact that you are giving surfactant through into the trachea in a tube that you cannot administer positive pressure ventilation through, and in a spontaneously breathing infant. There are other somewhat less invasive techniques as well that have been tested. Using a laryngeal mask airway to distribute surfactant has been tested by the group in Albany with some success. And pharyngeal administration, which actually was tested first in the 1980s in Morley's original surfactant trial, and is being tested now in Ireland, may also allow babies simply to have surfactant administered to the hypopharynx and have the baby aspirate surfactant without any positive pressure. But lastly, and one that I think holds people's imagination, is the idea of nebulization or aerosolization, where infants simply receive aerosolized treatment while they're breathing spontaneously. What we'll talk about in detail today, because there's a wealth of evidence, is thin catheter administration, but we'll touch on the one larger trial of nebulization just to see where we think things might go in the future. So let's discuss thin catheter surfactant administration, shown here with the baby, the model being having a laryngoscope to visualize the cords, having a thin catheter, in this case guided with McGill forceps to pass into the trachea. There was a recent review, pending publication, by Abdul Latif and colleagues on surfactant therapy via thin catheter in preterm infants with or at risk of respiratory distress. The literature is growing. There are 16 trials involving 2,164 infants that are included in this review. There are many methods that have been used in the trials regarding the techniques of catheterization and surfactant delivery. They all differ slightly, feeding tubes versus angicaths, with or without pre-medication, and there may be room to research these issues further. But the issues seem small compared to the core issue of giving surfactant to the spontaneously breathing baby in this fashion. And therefore, for this review, these methods are all grouped together. I think it is important to understand that there are two possible treatment strategies that can be used in identifying patient populations that might benefit from thin catheter administration. One, as shown here in this cartoon, is a head-to-head comparison pitting thin catheter administration directly against Ensure. And by that I mean that in a patient who has achieved whatever level you've decided warrants surfactant treatment, at that point either they are treated with thin catheter administration or given Ensure. There's another strategy, though, that tries to play on the possible benefits that thin catheter administration may be less invasive and may make an infant's surfactant sufficient, perhaps in an earlier course in the disease, leading to better outcome. This compares thin catheter administration, perhaps at an earlier point, to more selective treatment, maintaining babies on CPAP and treating them later on in their course of disease. In this review, they are discussed separately and also combined together. The review did identify 16 studies, 12 of which compared that head-to-head comparison of thin catheter administration versus Ensure, and the other 2 of them looked at thin catheter administration compared to more selective treatment of infants who stay on CPAP and are treated later on in their course. Looking at the need for intubation within the first 72 hours, here we can see the studies that compared thin catheter administration to Ensure, and here the 2 studies that took a look at the more strategic approach to thin catheter administration versus endotracheal intubation for infants with respiratory insufficiency. What we see is a strikingly strong result regarding improvements associated with minimally invasive surfactant administration. When it comes to the head-to-head trials, we see a typical relative risk of 0.61 and a typical risk difference, the point estimate of -12, suggesting here that perhaps for every 8 babies we treat with thin catheter administration, we have 1 less baby that requires intubation at 72 hours. In the 2 studies that looked at a more strategic approach, we also see a very dramatic decrease in the need for intubation within the first 72 hours, suggesting that for every 5 babies we treat this way, 1 less baby will need intubation by 72 hours of age. Importantly, we also see downstream clinical benefits regarding bronchopulmonary dysplasia. When we look at the head-to-head comparisons, we see a decrease in the risk of 43%. That may be as much as a decrease of 56% to as little as 25%, and a point estimate for the risk difference of -0.07, suggesting that perhaps for every 13 or 14 babies that we treat with a thin catheter, we have 1 less infant having bronchopulmonary dysplasia. The results regarding the more strategic approach trend in that direction, but there are fewer studies on which to report. Only the CRIB study really reports on this. And so it still holds great promise, but is uncertain. Similar to the results on BPD, we see decreases in the combined outcome of BPD and death of similar magnitudes, suggesting that perhaps for every 9 babies we treat with minimally invasive surfactant administration, there's 1 less child who either dies or has BPD. To my mind, these are strikingly strong outcomes for what appears to be a relatively small difference in administration techniques. I think that the answer will be sealed when we get the results of the soon-to-be published Optimus trial. This is a trial sponsored by Peter Dargaville and his crew in Tasmania, involving Australasian and North American and Turkish centers, in which they treated infants with minimally invasive surfactant therapy. This is more of a strategy trial. Infants were eligible if they were on CPAP and had FiO2s of greater than or equal to 0.3 at less than 6 hours of age, and were randomized either to receive surfactant via thin catheter or sham treatment. CPAP was continued in the groups unless they met predefined intubation criteria. The results of this trial are pending and are of sufficient numbers, with the over 480 infants enrolled, as to probably seal our interpretation of whether or not such thin catheter administration is truly the advantageous way to go. To finish up, I'd like to touch on this issue of aerosolized surfactant administration because I think it has all of our imagination and because we are aware that there is a large collaborative trial that was recently published that began to address this issue. In the aerosolized calfactant trial, calfactant was aerosolized to infants who were having mild symptoms of respiratory distress. There were 22 NICUs that participated and 457 infants were enrolled. It was a very broad population ranging from 23 to 41 weeks. 230 infants were assigned to aerosolized treatment and 225 received 334 treatments, starting at a median of 5 hours. What the authors report was a significant decrease in the number of infants who were intubated if they received aerosolized calfactant, 26% versus 50%. They also saw a somewhat concerning increase in the risk of air leak associated with the aerosolized treatment. Importantly, the authors do not report some of the other meaningful downstream consequences. This is a very exciting trial, a very exciting approach to giving surfactant. But Glaser and Wright comment in Pediatrics some of their concerns around the trial itself. They agree this is a very promising direction regarding the feasibility and safety of aerosolized surfactants. But they comment that despite these promising results, the study design potentially introduced significant bias. Notably, there were no criteria for surfactant therapy in the randomly assigned groups. And this brings us to a more general question in our world of trials and evidence-based medicine, and that is understanding the difference between pragmatic and explanatory trials. The authors here jumped in and did a pragmatic trial, a trial that seeks answers to whether an intervention will work under the usual conditions. They did not do an explanatory trial, trials that are best suited to test causal hypotheses in a setting where confounders can be minimized to the greatest degree possible. To my mind, we weren't quite ready for a pragmatic trial. We needed something more explanatory. We needed a narrower patient population, one that we knew had RDS, not just respiratory distress. We needed more methodologic rigor. We needed protocolized interventions regarding when we would intubate infants and how we might manage issues around surfactant dosing. And of course, we needed to hear about the more meaningful clinical endpoints. In a higher risk population, we needed to know about BPD or even death. And so to sum up from our Canadian friends, some of the relevant recommendations regarding these approaches, the Pediatric Society recommended that in neonatal care settings where continuous positive airway pressure is routinely used to stabilize preterm infants, and when the rate of antenatal corticosteroid administration has been high, prophylactic surfactant is no longer recommended. They also note that non-invasive respiratory support should be provided to preterm infants with respiratory distress syndrome from birth. Early surfactant should be provided for newborns with increasing severity of RDS, demonstrated by escalated or sustained oxygen levels or by other clinical indications. They thought that as a cut point, infants with RDS whose oxygen requirement exceeded an FiO2 of 0.5 should receive surfactant replacement therapy. And I might argue that that cut point should be much lower than that. And lastly, and I think most interestingly, they argued that for spontaneously breathing infants on CPAP with RDS, non-invasive methods of surfactant administration, such as LISA and MIST, are preferable. This is a fascinating new approach, one that I'm not sure that I agree with, but we can discuss more as we flip the classroom. So please join us when we discuss your center's current standards and recommendations, as well as your approach to some cases that we'll select as Dr. Ehert, Dr. O'Reilly, and I debate the current use of surfactant. Thank you very much. Hi, I think that we are live now, and I would just like to say hello and welcome people. I apologize that I ran over a little bit, but there's so much to talk about with surfactant. As we enter this flipped classroom, I again remind you that I have some conflicts of interest, and certainly in my previous work as a consultant with pharmacy, but I believe they are not as consequential, having not worked with them for over 10 years. We'll talk a little bit about developing more of our understanding and find out a little bit about how you all feel about these issues at hand. I welcome my partners, Danielle Ehert and Deirdre O'Reilly, to discuss this with us further. So let's get into the flipped classroom and begin to discuss some of the questions. So let's take a quick test to see if, in fact, this can work. Look at you guys. So I see, first of all, it's exciting that close to 40%, a little bit more, have not participated before in a Cochrane webinar. And so welcome. I didn't include the choice that I can't remember, or I promised myself I never would again. But it looks here that we've got only a little over half of you who have joined us before. So welcome. We look forward to your participation and your feedback. So let's get into it. Let's discuss a little bit about what we do, how we use this evidence in our practice, and discuss some of what we know about the benefits and harms of surfactant therapy, both the desirable benefits and the undesirable effects. So here's the first poll question. Trials of surfactant replacement therapy have not been shown to decrease the risk of which? I feel a little bit like the tricky professor when I ask you this question, and that is because it probably does decrease the risk of death or BPD. It doesn't decrease the risk of BPD alone, and it certainly decreases the risk of mortality. But there is little or no evidence that it decreases the risk of intraventricular hemorrhage. And I would be curious to sort of hear from our discussants what their thoughts are about the understanding of the effect of surfactant therapy.
Well, I think it's notable how many positive downstream effects we see from surfactant administration. So it's really interesting that it does not have an effect on intraventricular hemorrhage, but it really shows us that even in these trials, we can't always get at that question of cause and effect. You know, what is really happening with every single mechanism. So it's interesting that none of the trials showed that benefit.
Yeah, you know, Deirdre, I do agree in the sense that had you told me that there's something that decreased pneumothorax, I think in the causal pathway that might have decreased intraventricular hemorrhage, but we don't see that in any of the trials, literally. The other thing is sometimes trials report outcomes that, like, say, decrease in neck. And you know, I don't know if we can grasp on that when literally hundreds of other trials have not shown it, and not say to ourselves, well, that's probably a random effect. The other thing I'm impressed with is I'm not sure that people know when they teach their house staff, or even when they talk to parents, what increased risks have been seen. And here we see from the poll that people have rightly identified that pulmonary hemorrhage is an increased risk. But a few have thought that perhaps patent ductal arteriosis is a risk. And the two are somewhat related outcomes, but let's just take a look at the data. It is pulmonary hemorrhage that we are most worried about. And interestingly, it was not something reported in the initial trials. We found this out once it was released and people started to report it. And Tansei Raju went back and looked at the original trials and noted that there was a almost 50% increase in the risk of pulmonary hemorrhage. The funny thing about that, of course, well, you know, maybe I can hear from Deirdre or Danielle. What do people think the cause of pulmonary hemorrhage is?
Roger, I think that's a great question. And looking at the great meta-analysis, you know, by Doctors Raju and Langenberg, you know, they just described, you know, what a multifactorial situation this can be. And certainly it is the babies at highest risk. that likely are at risk of pulmonary hemorrhage. Out of the 11 trials that are listed, it was only the Stevenson trial that actually did show an increase in pulmonary hemorrhage on its own. And notably, that was the trial that had the smallest babies, birth weight of less than 700 grams. And so that was, one kind of take home point, I think, from the meta-analysis. When thinking about the harms of surfactant, I think it's really important that we look at all of these 11 trials together. It wasn't until we had this pooled evidence that we could really see the increased risk of pulmonary hemorrhage. Although, the authors do conclude that it is a relatively small increase risk. We have our typical risk of 1.47. That's averaged over these 11 trials. They showed it notably in the control that was about a 2.4% risk of pulmonary hemorrhage, and in the treated with any type of surfactant, it was 3.6. So although it is an increased risk, they noted that it was relatively small, and putting that in the context of the profound and notable benefits of surfactant that you showed us in the first half of this flipped classroom. But one thing that I think is a theme of this whole entire seminar is context really does matter. So when I think about putting this evidence, into practice, although it's a small risk, and I'm thinking about, my local practice, our colleagues that have limited or no mechanical ventilation, which might be used to treat, the rare but serious side effect of pulmonary hemorrhage, they might interpret this data, a bit differently, especially if they're at the point of trying to plan how to implement surfactant therapy. So context always matters.
Yeah, so great points. I agree with you too. This is one of the many examples where the meta-analysis, seeing the forest for the trees, actually was truly illuminating, because this safety concern really was brought up by Tansei's meta-analysis and the trial investigators going back to get this data. The other thing I noticed is that a few people answered that the risk of PDA was increased. And of course, it's funny, our conventional thinking is that pulmonary hemorrhage is hemorrhagic edema from PDA shunt. And the natural history of PDA may change with surfactant therapy. It's suggested by animal models, it's suggested by this. We may see earlier and larger shunting. Overall, the same number of infants wound up diagnosed with PDA and treated for PDA. But whoever answered PDA might have been thinking that, hey, the natural history is changed by this. So all good points. All right, so let's move on to this issue, which I think is of the greatest interest, and that's the how and when to treat. And let's start with what we know about Ensure. This asks you whether or not trials that demonstrate that the early use of Ensure compared to stabilization on CPAP and selective surfactant treatment decreases the risk of death or bronchopulmonary dysplasia. So watching the poll things go up and down there, most people picked up, I think, from the meta-analysis that we presented that it really doesn't, but it really is just on the cusp there of having a trend towards perhaps some improvement. So the answer here is that everyone is right, I think. From our own experience in the Vaughan delivery room trial led by Michael Dunn and colleagues, it's very clear that prophylactic surfactant and keeping the kids on ventilation is an undesirable method of management, but much less clear regarding whether or not Ensure versus CPAP and selective treatment are either one is superior. And again, just going back to this meta-analysis, we can see that it's sort of just on the borderline there about whether or not there's a benefit. So what about our practice? If I could ask Deirdre or Danielle, what do we feel about Ensure? What are we getting chatted in about the approach of using Ensure?
Well, we had an excellent question. This might be a good time to switch to the chat. Nathan Sundgren asked the question, or brought to light the question about the LISA MIST versus Ensure trials not being exactly head-to-head, and that they did use very different oxygen thresholds for that intervention. And so he was wondering what the thoughts from the panel were about that, whether you know, is that a true comparison because there was such different criteria in between the trials?
Well, some did and some didn't. Okay, and that, as I hope, was part of the point of the fact that there are really two questions on the table, much as the chat implies. Does it really matter in the same situation that this delivery mode is different? And if it is different, I mean, a bigger tube doesn't sound like such a bad idea with Ensure, but I guess the problem there, even if it's truly head-to-head, is that it allows us the mischief of bagging the kids and giving positive pressure. So there are, Deirdre, some trials which really did head-to-heads, identical criteria comparing the two delivery methods, and they still showed differences in outcome. Again, perhaps because of not introducing positive pressure. The trials that interest me the most are the ones that say are more selective, such as what the questioner brought up. Can we have slightly different criteria? Are we more willing to sneak in earlier with less invasive support? And we'll talk about that in subsequent questions. So let me move on and let's ask about just this. Have people used any of the newer approaches to surfactant administration, including thin catheter administration? But let's even think broadly, LMA administration, pharyngeal deposition, or were you part of the aerosolized trials? And I think this is very interesting because, I mean, this is how adoption occurs, right? Some of us jump on board early and some of us hold back. And this distribution is quite interesting that almost 40% of us have used one of these newer techniques. And again, I'll just reiterate what was seen. And that is even for the direct head-to-head comparisons, we see that there's some improvement reported with the thin catheter administration. And there's less data on what I feel to be the clever studies, namely can we time it differently and get surfactant in earlier and show some advantage. But in either case, there's a great deal of promise regarding the need for intubation, and potentially there's at least a decrease in the Ensure versus thin catheter work that suggests that important outcomes like death or BPD may change. But my question, though, really, are we ready for this? We have more data coming down the line. What's going to push us at UVMMC to consider this change?
That's an excellent question. I think you know, it's difficult with so many different methods out there, all aimed at the same goal, which is to reduce lung disease in these very vulnerable babies. But we have so many people to train, so it brings up that question of efficacy and effectiveness. You know, how do we train everybody in a way that we feel confident as attending physicians, and that everybody in the unit, from our fellows and residents to respiratory therapists and all the other important people who contribute to care that we deliver to these babies. And it actually, in the chat, there was another really good question from Shilpa Vyas-Reed about are there any safety data about these newer methods in the very small babies, those less than 750 grams. So I was wondering if you could speak to that.
So safety is always interesting and evolves because, you know, the efficacy studies, fewer patients, clear sample size, but safety emerges. Most of what people have been worried about with safety has been bradycardia or other complications or failure to be able to place the treatment. And, you know, there are some complications, but nothing too worrisome. I think your point, though, about the fact that translating this into practice will not necessarily be easy. For this discussion, I pulled out this work from Sawyer and colleagues, just showing just how much work we have to do just with conventional intubation already, and the failures. Danielle, I know you have to think about this in other care contexts. What do you think the barriers are going to be if, in fact, these studies do show us that thin catheter administration is superior?
It's a great question, Roger. I think, Deirdre brought up the great point of, intubation is a skill, a learned skill, and one that needs a lot of practice. So, just as we have all seen the change of less intubations without meconium, we may also foresee less intubations when we're not using it as often for surfactant. So I think that's a kind of a global, potential concern, but also if there are, methods that are using new devices or new consumable products that are very hard to come by. I think just, the cost and the systems issues are always just a very real concern to be mindful of.
Yeah, the chat is full of stuff about the ease of LMA, which is of course an interesting thing, but that is again a new product, a new skill, but that's also an interesting emerging thing. So let's end up with a couple of things, just asking you guys in the audience about how you would approach treatment in a case. And I made the case fairly simple, but I'll run through it real quickly. It's a 27-week gestation. So it's a baby that unequivocally we're going in to resuscitate, and we believe that we can optimize outcome. It's a 25-year-old mom who has no great medical past, but she's in preterm labor. She's unresponsive to tocolytics. She's been given full antenatal steroids. APGARs are good, and you've successfully stabilized this little one on CPAP. There are no signs of respiratory insufficiency, and by that I mean we don't have a increasing CO2, but we do have an increasing oxygen demand. And the question for the poll is, at what point would you consider some introduction of surfactant treatment? And I think it's very interesting, and by the way, consistent at least with my practice, that there's a pretty low threshold. 60% say 30%. Thoughts from my colleagues on this?
I think this is very interesting as well, Roger, and I also answered A. This is our institutional policy, and what I thought was so interesting as we looked at some of these trials, this actually made us ineligible for some of these trials because the protocols were an oxygen requirement greater than 40%. And so, we felt a bit uncomfortable to change from our local practice to a guideline that was a bit higher. And it looks like we're in good company.
Right. And interestingly, though, the sort of the purist would go up to 50%, and yet very few of us would nowadays. And I frankly, I agree with that approach. And how would you give surfactant to this baby, no matter which threshold you chose? 30%, 40%, 50%. How would you currently give surfactant to this infant? So interesting, those that are answering A are old school. This is who I would have been in the past and probably takes a lot to tear me away from. But I know at our institution, Danielle and Deirdre, did you guys answer B? Okay, so we are an attempt at ensure in terms of our approach. Of course, it's all about the E of ensure. It's, do you actually extubate this baby? Do you leave this baby lingering on positive pressure support? And therefore, have you done the child any favor? We're not going to have time in this session, but then the whole issue of retreatment criteria, especially if you've extubated the baby, becomes of some interest. But let me just end with a general question that I don't have questions for the poll, but what are the changes when we think of the 24-week gestation baby? And I'll start with Danielle and Deirdre, but we'll try to look at the chat for any comments to throw in before we close.
So I think, a 24 and a 27-week baby are very different babies, even if, they are had received antenatal steroids and are spontaneously breathing. I think we often wonder, what level of spontaneously breathing, is sufficient? Do we have the correct size and staffing to really optimize and keep this baby very well supported on CPAP or non-invasive support? I think one thing that always comes up for discussion for us is how good is the dating? If our institutional guideline is really just based on gestational age, is that good? We know that can be, quite variable, especially depending on, is it LMP, is it an ultrasound? How early was the ultrasound? So I think there are a lot of challenges when we look at guidelines that are just based on gestational age.
always have this problem. We do the research in well-defined populations, and then we turn around the very next minute, it seems, and have to think about the populations that aren't tested by this. And it's such a unique population. I'm looking at the chat. I'm seeing a lot of people saying, we're not comfortable just with insure, that we would continue some ventilation afterwards. I'm seeing other people saying that's very case specific, depending on how much spontaneous breathing they see, etc. It's always hard when we extend from the trials, which have not adequately studied this population. It's always hard when these populations are so emotionally difficult with the problems we have, when we know we should study them better. And I'm not so sure as a community that we get together and do it. I'm also seeing some comments about minimally invasive surfactant that I think Deirdre alluded to, which is that the systems issues involved in these choices are very problematic. Teaching people these new techniques, questions about things I saw in the chat about video laryngoscopy are going to be challenges as we move forward. Deirdre, I didn't hear from you. Any final comments on our 24-weeker?
No, I think I wanted to echo what you just said about the systems challenges. I think it's one of the things I enjoy about this series so much is hearing from other places that do things. Some of the chat has been, well, essentially, why are people not using these less invasive modalities for surfactant administration more readily? And I would just say that from someone who does the fellowship education at our institution, it really does take a lot to change the system in the way that we teach things. But I look forward to sharing and hearing about others' experience with this, because I think we are all excited about this and think that it is part of certainly the future.
So let me end with a final question that really reflects everything we've been talking about, and I guess is the take-home point. Does your center have formal guidelines that address the indications, and by that I mean the patient population and the degree of illness, as well as the method of surfactant administration? And I'm loving the answer, because I would hope that the majority of people have this, but I love the fact that there is a significant minority that I hope fervently goes home and really thinks about this evidence, does not necessarily embrace it all, but looks at the older US recommendations, the European recommendations, the Canadian recommendations, and contextualizes it to their hospital and their resources. Danielle, I'm guessing that whatever guidelines that people would make in low and middle income countries would be very different than the ones strictly studied in trials.
Absolutely. I think you already had said it, context really matters. And so, yeah, I think that's very true.
But I'm loving the fact that I hope that it looks like almost 1 in 3 of you can go home and say that there is new information, there are new guidelines, there is reason to rethink our approach to this very fundamental treatment in neonatal medicine. So on that note, I'm just flashing up the last recommendations. I'm not going to go through them again, but please do give that further thought. I hope that we provided food for thought. I'd like to, of course, thank Danielle, Erin, and Deirdre O'Reilly for joining me and making this an interesting discussion. And thank you all for coming and joining us. I'm going to turn things over to our managing editor, Colleen Ovalman, to talk to you a little bit about what's coming up in the near future. Thank you.
Thank you, Roger, and thank you, Deirdre and Danielle. Everyone who's participated today, if you registered beforehand, you'll be receiving an email with information on how to complete the survey to receive CME or continued nursing credits. If for some reason you do not receive that survey and you participated today, then please feel free to email me. And just to let you all know that we will be having our next webinar in this series on June 28th. It is a network meta-analysis of postnatal corticosteroids in preterm infants. So we will send you all out more information about that as it becomes available, and look forward to seeing you on a seminar again soon.
Thank you. Bye.